I'm Jaya Ganesh, and I'm an associate professor in the Department of Genetics and Genomics Sciences at Mount Sinai. And today I will be talking about inborn errors of metabolism that manifest with liver disease and the emerging phenotypes uh, that we are seeing, and the impact that the recent advances in genomics has had in the way we approach these problems and treat them, and increasingly embrace precision medicine in these disorders. I have no conflicts of interest to report. I have consulted and received research funding from the following companies, but nothing to declare related to this presentation. And this webinar is part of a series of specialty webinars and a few housekeeping issues. Please enter questions in the Q&A box below, and we hope to have some time for discussion at the end of the talk. And importantly, please feel free to suggest topics for future webinars and provide specific feedback. We would appreciate that. And please stay tuned for upcoming webinars. The next presentation is on Thursday, the 25th of February, and my colleagues, Dr. Mintz and Dr. Lozano, are going to be talking about the genetic evaluation of short stature. So for this webinar, the goals are to review the expanding spectrum of inherited metabolic liver disease. Advances in genomics are reshaping our approach to clinical care, and we will review clinical vignettes that highlight the applications of genomics specific to inherited metabolic liver disorders as they pertain to the diagnosis, management, and where we are going in the future in the management of these diseases. So if we think about the burden of monogenic liver diseases, in children in particular, it is a significant a problem in both in the outpatient setting and in the inpatient settings in the intensive care units, and account for about 50% of chronic liver disease presenting in childhood, and are quite common once we've excluded biliary atresia and autoimmune disorders. And 20% of pediatric liver transplants are currently being performed for monogenic liver disease, including those involving metabolic pathways expressed in the liver. And if you look at the adults, in addition to hemochromatosis and Wilson's disease, which are classic metabolic diseases with a hepatic phenotype, increasingly we are seeing variants in novel genes that are found to be impacting the phenotype in common disorders. For example, the genetic risk for hepatic steatosis is known to increase due to certain variants in the PNPLA3 gene, and atypical presentations of common diseases are also thought to be due to genetic disorders as opposed to exposures to alcohol, for example, in steatohepatitis. So as a metabolic physician, when I think about involvement of the liver, the problem is in a metabolic pathway, there is typically an enzyme deficiency, and the pathway does not go from substrate A to substrate B because the enzyme doesn't work. So you may have accumulation of toxicity upstream of the block and deficiency of compounds and synthetic functions downstream of the block, and energy deficiency, and particularly mitochondrial defects, can cause more of a global problem, altering the internal milieu of the hepatocyte. So we can recognize liver disease due to accumulation of a toxin. And the phenotypes seen are liver injury, particularly acute liver injury, acute liver failure, or more chronic presentation with fibrosis and cirrhosis. And in some instances, these may progress to the development of hepatocellular carcinoma. There can be impaired hepatic function, including impaired biosynthesis. The classic examples are cholesterol biogenesis defects, Smith-Lemli-Opitz syndrome, bile acid synthetic defects, and so on. Disorders that have a more chronic presentation with insidious liver disease, usually caused by storage, lysosomal storage disorders, glycogen storage disorders, resulting in organomegaly, which may be either isolated hepatomegaly or hepatosplenomegaly, and energy metabolism disorders, which also cause liver injury and steatosis. So while there is an overlap, um, certain presentations are easily recognized. And here is a cartoon so that shows some of the more classic pointers that a child or a neonate who's presenting with liver disease probably has an inborn error of metabolism as the underlying pathology. So, in a very sick newborn, one has to think of disorders like galactosemia due to exposure of lactose even in breast milk, mitochondrial disorders. All metabolic diseases can present with subacute liver failure, and then there may be some telltale laboratory manifestations like an elevation of ammonia, persistent lactic acidosis, severe hypoglycemia that is out of proportion to the degree of liver injury and metabolic acidosis, and involvement of not just the liver but more of a multi-system presentation with encephalopathy, ray-like presentation, involvement of extrahepatic tissues that are highly metabolically active like the liver, including skeletal muscle, the heart, central nervous system, proximal tubule, bone marrow, non-immune hydrops. So when you get a combination of the liver plus extrahepatic signs and symptoms, that should raise the suspicion for an inborn error of metabolism. And another important thing to remember is these patients may have episodic worsening with triggers, and the trigger may be a diet, like fructose in the diet or galactose in the diet. And once the trigger is removed, the liver injury gets better. So, this waxing and waning presentation episodicity is also a classic feature of metabolic diseases affecting the liver. So here are some examples of inborn errors of metabolism that we see with some of the descriptive presentations: the acute liver failure, cholestasis, hepatitis cirrhosis, steatosis, hepatomegaly, hepatosplenomegaly, where the spleen enlargement is more prominent than the liver. And under these categories, I've listed some of the disorders that we encounter, and the purpose of this presentation is not to go through each one of these defects, that will be more like a 3-day workshop, but just to highlight how some of these metabolic diseases can manifest. And also highlighted in blue are those disorders which are picked up now on newborn screening. And it's important to note that the newborn screening, the number of disorders that are being added to the screen is gradually increasing with better technology and is an important tool in our arsenal when we approach these diseases. So this is a brief history of the New York State newborn screening, and those of you who want more information, I'll refer you to a webinar that Dr. Diaz did in July of last year. And just to briefly mention, the newborn screening started really with PKU in the 60s, and gradually many diseases have been added. But there was an exponential increase in the early 2000s when we had technology like tandem mass spectrometry that became available, and the number of diseases that were added onto the screen increased. And now we not only screen biochemical testing for these disorders, we are able to do DNA-based screening. So in addition to the biochemistry, a molecular genetic confirmation arrives with the result of the newborn screening within a few days of the child's birth. And here are some of the diseases and that we for this talk are interested in: galactosemia, tyrosinemia, organic acidemia, fatty acid oxidation defect, cystic fibrosis, etc. And more recently, other disorders are being added, including lysosomal storage diseases and peroxisomal storage diseases. So every state is different. There are a few core basic diseases that are screened for, and then other additional diseases are part of the expanded screen. And New York State currently screens for about 60 disorders, and this number is bound to increase. So when we think about the diagnosis of a sick child who's presenting with an acute liver phenotype, in the past, there was suspicion from clinicians of a rare disease. However, we did not have the technology, and what technology was available was primitive or resources were limited. So we did go through biochemical testing. Invasive testing was done more often and earlier on in the algorithmic process, and genetic testing was limited. And results were inconclusive, and we had a lot of dependence on basic research lab because commercial testing was not available. And many patients were dumped under the umbrella of idiopathic hepatitis or some other non-specific diagnostic label. And patients also found themselves on a frequent diagnostic odyssey without confirmation of what is going on with them. And some of these were lasting months, years, and sometimes patients died without a definitive diagnosis. And this was really true up until the mid 2000s. But there was a big shift in the last few years where we have better tools, including screening tools. One, so now when a disease is suspected, clinical suspicion of rare disease, we go straight to the screening tools. We first look for the newborn screening. Was anything present on the newborn screening? Was there any suggestion of one of the acute presentations or more of a chronic disease? And in addition to the newborn screening, many patients, couples are opting for prenatal carrier screening. And those are screening for upwards of 250 to 280 disorders. And sometimes there is information there that may be relevant to the child's presentation. So these may be informative even before symptoms develop in a child and are important to look for. And then we proceed with non-invasive testing. And in addition to biochemical imaging testing, gene sequencing is finding a place higher up and earlier on in the diagnostic algorithm. And while single gene sequencing is opted for if the diagnosis is pretty obvious or the suspicion is strong, most hepatologists and clinicians are going for multiple gene sequencing by means of these multiple panel-based genetic testing. And these are all possible because of these next generation sequencing technologies that are increasingly available to us. And the chances of nailing a diagnosis are much higher with these newer massively parallel sequencing techniques. And once the diagnosis is established, then that paves way for tailored and targeted therapies. And sometimes we may not get a diagnosis and we may have to resort to invasive testing. But that is done with a definite plan and a calculation, and sometimes the diagnosis is confirmed. And if invasive testing is also negative, we do have a pool of patients where the diagnosis is still elusive, but this cohort of patients is becoming smaller. And the more we get into the diagnosis and accurate diagnosis, the more our understanding of these rare diseases and the various phenotypes is increasing, and that is driving the algorithm forward in the correct direction with benefit to the patient. So the other big place where genomics has changed is in the management of patients. So we were always very conscious in the metabolic clinic of avoiding triggers. So metabolic diets came about fairly early, soon after newborn screening for PKU was established, even in the 80s and so on. And the diets have expanded to include a much bigger spectrum of diagnosis, and commercial formulae are available that are specific for various diseases. For galactosemia, it is simple. You avoid dairy and the child is on soy formula. But for other disorders like maple syrup urine disease or other organic acidemias, special diets are available. And the metabolic dietitian is the backbone in the management team of these patients. A second strategy is to prevent, and if we cannot prevent, we remove the toxic buildup upstream of a block in a metabolic pathway. In the urea cycle defects, for example, we have ammonia building up, so we use special scavengers to remove the ammonia and excrete it in the urine. But specifically to liver disease, tyrosinemia, for example, a biochemical has recently been introduced in the management of these patients that has completely changed the presentation of these individuals. And I'll be talking about this in subsequent lectures. Chelation, cornerstone in the management of patients with liver diseases, and we also use dialysis in the acute setting when when the medical management has failed and we need to optimize the care a bit. A third strategy is correcting metabolite deficiency downstream of the block. So classically, in Smith-Lemli-Opitz syndrome, where endogenous cholesterol synthesis is severely impaired, giving rise to liver failure, deficiency of bile acids, deficiency of thyroid hormones, etc., replacement of cholesterol is not curative, but certainly improves the clinical care of these patients and improves their overall health and well-being, and resolves some of the failure to thrive and liver disease that is seen. Synthetic bile acid supplements are key in management of bile acid synthesis defects and so on. Replacing and restoring a functional enzyme in a pathway. So the prototype for these disorders has been recombinant enzyme replacement therapy for lysosomal diseases, which started about 20 years ago. But this concept is expanding to involve other metabolic disorders. For example, there is an ongoing clinical trial for homocystinuria using enzyme replacement therapy in our institutions. So this is becoming active. If an enzyme is defective but it's non-functional, a new strategy is to use small molecules as chaperones to stabilize a defective enzyme and increase its efficiency in vivo. And this is a very neat concept that is being used in the management of some disorders. Organ transplantation is an option for some of the patients, especially those where the quality of life is so poor with recurrent metabolic decompensation and severe injury to multiple organ systems, and risk of death is imminent. So in those patients, and also in other patients where we don't wait till they get to that severe presentation, we anticipate severity of the disease, and we are being a bit more proactive and are moving towards earlier transplantation to improve outcome. And both in inborn errors of metabolism, we are using both liver, kidney, and in some situations, cardiac and other organs. Gene therapy and RNA-based therapies. There are many clinical trials that are involving AAV-based DNA delivery that are liver targeted for various disorders. And we will discuss this in subsequent slides. And the dogma is DNA to RNA to protein. After DNA, RNA can be used and manipulated to deliver therapeutics to the pathway. Nutritional support is very important, and any complications that arise from these disorders need to be efficiently identified and managed. And last but not least, prevention. And this is another important place where advances in genomic techniques have enabled diagnosis, prediction of recurrence risks, genetic counseling, and where there is a recurrence risk, assisted reproductive options, including pre-implantation genetic diagnosis or prenatal diagnosis, is possible. And at our center, we are lucky in that all of these services are available, and patients with liver disease usually are managed with a multi-pronged therapeutic approach that is often needed in these patients. So here are some clinical vignettes that highlight, this one highlights the role that newborn screen played in the diagnosis and management of this little baby who at 4 days of age presented with feeding difficulties and was very ill appearing. And if you look at her labs, she was severely hypoglycemic with elevated transaminases and severe coagulopathy. She was diagnosed with acute liver failure and was treated appropriately with IV fluids and fresh frozen plasma, but was very dependent on FFP and a high glucose infusion rate to maintain hypoglycemia and keep the coagulation profile within range. And at around 7 days of age, they transferred her to Mount Sinai for evaluation for a liver transplant. However, we were fortunate in that she screened positive for galactosemia, and now we had the diagnosis. We know the natural history of galactosemia. The coagulopathy and the synthetic dysfunction takes a while to resolve, but it does resolve with supportive management, and we were able to reassure the parents and the treating NICU physicians that this will get better. And sure enough, by day of life 25, she was able to go home on galactose restricted diet and supportive therapy. And now she's an 18-month-old, thriving, developmentally normal child. There are some long-term complications, but the newborn screening weighed in with a definitive diagnosis, and we did not have to go down the route of transplantation and so on. To contrast, this is a child who was born outside the United States. And it's important for us to remember that the newborn screening is not available universally. And so we have to be mindful of some of these patients that show up in our clinic where they don't have the benefit of screening. 9-month-old born outside, failure to thrive, had an enlarged, very firm liver, and had elevated transaminases and synthetic dysfunction. And the hypoalbuminemia and coagulopathy was actually somewhat worse than expected for the elevation of transaminases. And we've seen that sometimes in galactosemia and tyrosinemia. And here is an ultrasound of the liver that shows nodular hepatomegaly and splenomegaly. And the suspicion was metabolic disease, and we initiated a workup, and plasma amino acids showed elevations of tyrosine and methionine. I wanted to point out here that any child with liver disease will have elevations in tyrosine and methionine because all of these metabolic pathways are active in the liver, and an inflamed hepatocyte, some of these pathways are dysfunctional. However, in order to make a diagnosis of tyrosinemia, we need to look at this compound, which is the signature compound, succinyl acetone. And in urine organic acids, this was detected. You can even detect it in the blood. And it's that presence of succinyl acetone in the setting of liver disease and elevated tyrosine that leads to a diagnosis of tyrosinemia. If we had not seen succinyl acetone in this situation, then we would not be comfortable calling it tyrosinemia type 1. We may have to do additional testing because this is very common in children who have liver disease for any reason. So do not be fooled by just elevations of tyrosine and methionine. You have to investigate further. So in this case, we found succinyl acetone. The diagnosis was tyrosinemia type 1 due to the deficiency of the enzyme fumarate acetoacetate hydrolase. And since tyrosinemia type 1 got on the newborn screening, and now there is a very effective treatment for it, the manifestations and the phenotypes that used to be seen commonly in the liver clinics and metabolic clinics is gone away. No, in the last 10, 15 years, I have not seen infantile liver disease that would present with hepatic failure, cholestatic jaundice or cirrhosis in a very ill infant who 3, 4 months of age, or a late childhood manifestation presenting with some of the liver phenotype and in addition renal rickets due to tubulopathy. And if in certain other patients, they may even progress to have hepatocellular carcinoma. So the phenotype is changing because we are able to diagnose this early and institute treatment. And important to note that porphyria-like attacks can present at any age in tyrosinemia. So I just wanted to briefly discuss this pathway to show you how treatments are changing the natural history of these disorders. So here is the breakdown of tyrosine. Phenylalanine is the essential amino acid that all of it is converted to tyrosine, and tyrosine goes through multiple pathways, and one important pathway is this one, and through multiple intermediaries, homogentisic acid, etc., becomes fumarate acetoacetate. And ultimately, fumarate acetoacetate should become fumarate and acetoacetate and proceed downwards. Fumarate will enter the Krebs cycle and so on. And in hepatorenal tyrosinemia, type 1 tyrosinemia, the block is the deficiency of the fumarate acetoacetate hydrolase, quite distant from tyrosine when it started up in the pathway. So when there is a block, the body tries to excrete this accumulating fumarate acetoacetate. It tries to convert it into this compound, succinyl acetoacetate, which then becomes succinyl acetone, and that can be excreted in the urine. Unfortunately, however, succinyl acetone causes oxidant injury, and it's pretty toxic. And in the liver and kidney, it gives rise to liver disease and proximal renal tubular injury, which accounts for the phenotype. And in addition, this compound can inhibit the porphyrin synthesis pathway. And in the liver, all of these pathways are coexisting. So here is the porphyrin synthesis pathway in the hepatocyte, the heme biosynthesis. Aminolevulinic acid is one of the early metabolites that becomes porphobilinogen by the action of the ALA dehydratase, and via a series of multiple subsequent steps, you have formation of heme, and heme, once formed, has a negative feedback inhibition and prevents additional formation of aminolevulinic acid. And aminolevulinic acid, when it accumulates, it's toxic and is responsible for a lot of the acute features seen in porphyric crisis. And porphyric crisis happen when there are blocks in this pathway, heme is not formed, and this negative inhibition is lost, and this toxin builds up. Succinyl acetone that accumulates in tyrosinemia type 1 has blocks ALA dehydratase. So it induces a break in the porphyrin biosynthesis, heme is not formed, and hence these patients can get a porphyric crisis. So this was the norm in tyrosinemia. They will have liver injury, kidney injury, and intermittent porphyric crisis. In the late 90s, early 2000s, biologists and metabolic physicians in Sweden serendipitously noted that a biochemical, NTBC, and you can look this up, it's a complex biochemical, it's actually a weed killer. They found that in the lab setting, it inhibited tyrosine metabolism at a level that's up this high. And so when you block the pathway this high, then you don't make fumarate acetoacetate, and you don't make succinyl acetone, and you don't get liver injury, and you don't get porphyric crisis. They entered it in clinical trials, and a huge cheer went up in the metabolic community in the States and in Europe in the early 2000s when it worked in patients. And this has been life-altering for patients with tyrosinemia type 1. And so now that's when it got put on the newborn screening, and we started screening, and those patients who are positive for tyrosinemia are now started. We do some dietary restriction of phenylalanine and tyrosine, but more importantly, they are started on NTBC, and it's lifelong therapy, and that has decreased all the complications, including hepatocellular carcinoma in these patients. However, we need to be aware of the phenotype. Here is a patient who was recently seen in our institution. He was 12-year-old, diagnosed on newborn screening, and has been on a metabolic diet and NTBC since birth. A month ago, he presented with a 3-4 day history of fever, abdominal pain, and emesis. And inadvertently, the NTBC got held because his PO intake was poor. And he was admitted in one hospital for IV fluids and then transferred to another because he wasn't getting better. And eventually landed up in Mount Sinai about 5-7 days after the onset of symptoms for management of metabolic crisis. And when his clinical features were severe hyponatremia, hypertension, self injurious behavior with altered mental status, focal seizures, classic manifestations of an acute porphyric crisis. And we felt that this was due to elevated succinylacetone. And when we measured his aminolevulinic acid, sure enough, it was sky high. Normal range is between zero point 0.2 and 2.5, and he had a value close to 70. We reinstated NTBC. And since we know the pathway of heme exerting a negative feedback inhibition, preventing accumulation of ALA, we used synthetic heme in infusions over a period of 3 days. And within 3-4 days, there was complete resolution of symptoms, and he's back to baseline. So I want to shift gears a little bit and move to some of the more newer diseases that are picked up on newborn screening. And this one, peroxisomal diseases, is what we're going to be discussing right now. The newborn screen included peroxisomal diseases, and they are measured by estimating this very long chain fatty acids. And the reason is, if you diagnose them pre-symptomatically, particularly in males, you can prevent the progression of adrenoleukodystrophy, X-linked adrenoleukodystrophy, that can be devastating in male patients. And the management is with bone marrow transplantation as an intervention soon after the symptoms start manifesting. The results are a bit mixed, but that's the standard of care as we know it. And so very long chain fatty acids are being looked at on the newborn screen. So there are patients who have elevations in very long chain fatty acids, but who don't have adrenoleukodystrophy. What they have instead are peroxisomal diseases, because this metabolite is catabolized subsequently in peroxisome. So elevations of very long chain fatty acids will diagnose Zellweger syndrome and Zellweger spectrum disorders. So here we have a patient who had a male neonate with very long chain fatty acid elevation, and the newborn screen is able to actually do the genetic testing as well for X-linked adrenoleukodystrophy that was negative. So right away, within a few days, we knew that this is not a standard XALD, and it's probably a peroxisomal disorder. We subsequently expanded the testing, and sure enough, he had variants in PEX gene that is associated with Zellweger spectrum. And he has global delay and hypotonia, hepatomegaly, transaminases, but he was relatively well. Zellweger can be a spectrum of very severe to a no milder presentation. However, as we were monitoring him, we noted, or hepatologists noted, elevated atypical bile acids, because you need functional peroxisomes for bile acid synthesis. And when you don't have normal bile acid synthesis, atypical bile acids build up and cause havoc. So the way to treat it would be to start him on a synthetic bile acid supplement. And we started this about almost a year ago now, and he's clinically stable, but it remains to be seen if this will be a definite a therapeutic option for him, because the data on using bile acid supplementation is somewhat limited and anecdotal at this point. But at the very least, we're able to institute the management and the hope that it will work. So here are some examples where diagnosis leads to therapy, and therapy allows us to explore newer options such as biologics in the management of these diseases. And another place where reliance on newborn screening is not possible is in those metabolic disorders that are either not identified reliably on the newborn screening, or have a milder phenotype and are not picked up, or they are presenting for the first time in people who have missed the current technology in screening, so the later onset manifestations. So here is a 14-year-old boy who's pretty healthy, well grown, normal growth parameters, was in mainstream school, but definitely had some mild learning delays and needed support. And as a teenager, he wanted to be on the soccer team. And soccer teams practice in the heat of summer for long hours. And players are told to improve their nutrition. So he went online, just like his friends, and bought protein shakes and so on and so forth. And within one short weekend, developed vomiting, altered mental status, and landed in the ED. And an astute ED physician ordered the ammonia, and that was what clinched the diagnosis, because ammonia measurements are not routine. And I really feel that if there's one takeaway from this talk, it would be if there's any child with altered mental status or any individual with altered mental status, make sure a metabolic disease is excluded. Once the ammonia was known, then it becomes easy. You get a metabolic consult, and he was diagnosed within days with OTC deficiency. The mutation was confirmed. He was put on the metabolic diet, and the phenotype was rescued. So emerging data supports a high prevalence of liver dysfunction in all urea cycle defects as indicated, and there are many good reference articles that are available. So patients with liver dysfunction and altered mental status should have an urgent metabolic evaluation. And also, not all inborn errors present in early childhood. And we have to be aware that there are late onset phenotypes. And if there are unexplained mental status changes, please have a free-flowing ammonia measured right away. So moving along, this is one of my pet topics, mitochondrial genetics, a very important cause of liver dysfunction. What are we dealing with here? Mitochondria are extracellular, extranuclear organelles which have their own DNA. So this is a structure of a mitochondrion, an outer membrane, an inner membrane thrown into folds called cristae that encloses the matrix, the mitochondrial matrix. And the importance of mitochondria, they are the powerhouse of the cell. So ATP production is from the mitochondria. But from our perspective, all the metabolic pathways, most of them at least, have a presence in the mitochondria. And any dysfunction or impairment of mitochondrial function is going to affect all of those pathways. So where do these mitochondria and mitochondrial DNA come from? This is the chromosomal DNA in the nucleus that encodes thousands of genes, as we know, and we are familiar with autosomal recessive, autosomal dominant, and X-linked inheritance of these genes. The mitochondrial DNA, on the other hand, is a much smaller piece of circular DNA, and it encodes 37 genes only, and is, for the most part, maternally inherited. There are rare exceptions, but traditionally, mitochondrial inheritance, maternal transmission is the rule. And the mitochondrial disorders are multi-system disorders, and the current pediatric incidence is thought to be 1 in 5,000. This is, we think, an underestimate because they're difficult to diagnose, and early mortality is often seen. And the liver involvement is seen in up to 20% of these patients. And if you think about a neonate with liver disease, 40% of them can be mitochondrial liver disease. And the other cool thing about mitochondrial DNA is that the chromosomal DNA does not replicate. Once cell division stops, you are left with chromosomal DNA that is in the cell. Mitochondria, on the other hand, are constantly replicating. And mitochondrial DNA replicates continuously and independently of cell division. And there are several mitochondrial DNA copies per cell. And how do we maintain so much mitochondrial DNA? It is a close crosstalk and interaction between the two genomes. And there are many nuclear genes that are important for the replication and maintenance of mitochondrial DNA. What is the importance clinically? Defects in those nuclear genes that important in maintaining and replicating mitochondria result in mitochondrial depletion syndromes. And in the pediatric population, the liver is one of the classic target organs in mitochondrial depletion. So here are a couple of cases. This is a child that I saw back in 2005. I was a newly minted attending, and this case will stay with me forever. She presented at 3 days with feeding difficulties, and as we were following her with the liver team, failure to thrive, hypotonia, and out disproportionate hypoglycemia to the extent that we were having to use octreotide and other measures that are not standard in these patients. Cholestasis, elevated liver transaminases, and severe global delays. And this is the picture. It is not just the liver, it is growth failure, global delay, extrahepatic manifestations. And nothing worked, and she was steadily getting worse, persistent elevated lactate, and the metabolic labs were abnormal, but nothing specific for any particular diagnosis. And she unfortunately died at the age of 9 months. And the workup was extensive, and this is a liver biopsy, which the oil redo shows the degree of steatosis is incredible. All of this orange is abnormal fat accumulation in the liver. And when we did the EM, we saw this proliferation of these circular abnormal structures. At first, we didn't know what these were. Turns out that these are abnormal mitochondria that are very abnormal, don't have any cristae or any shape. And when we measured the amount of nuclear DNA and mitochondrial DNA, this is a control on the right side with a nice band of nuclear DNA and a healthy amount of mitochondrial DNA. And in the patient, we had nuclear DNA, but the mitochondrial DNA band was washed out very little. So we knew this was mitochondrial DNA depletion. We sang a sequence, meaning individually sequenced a couple of genes that we knew that can cause depletion, and they were negative. And so it was very awkward and awful to tell this young couple that their first child died from unknown causes, and we had no information to give them for future planning and family, etc. But fortunately, a year or so later, the MPB gene was identified to be associated with mitochondrial depletion. So one by one, genes were being associated with phenotypes in those days. And Dr. DeMauro in Colombia helped me sequence this patient's MPB gene, and we identified pathogenic mutations and nailed the molecular diagnosis, MPB gene related mitochondrial DNA depletion, 18 months postpartum. Parents were carriers and subsequently went on to have a successful pregnancy using this information for pre-implantation genetic diagnosis. Contrast this odyssey with another baby born recently in 2020 in the middle of COVID, a newborn with tachypnea was transferred into Sinai. And again, severe metabolic acidosis, elevated anion gap, elevated lactate, severe hypoglycemia, and liver enzymes were elevated. And all of us were upset that this most likely was a mitochondrial disease. However, another twist in the tail for this child was her ammonia levels were galloping. She arrived with an ammonia of 80, and the next day it was in the 100s, and the third day it was in the 476, despite treatment with ammonia scavengers. And she had abnormal cardiac function. So we had our differential diagnosis. We sent some metabolic labs. They were inconclusive, but we dialyzed her. And after dialysis, she improved. Lactate was persistent. However, we did not know what the long-term prognosis is going to be. She improved and responded to dialysis, but will she sustain the So around about this time, the Sinai is partnering with Rady Children's and another commercial lab, and is part of this NIH-funded study, which is the Genomic Medicine for Ill Neonates and Infant. The acronym is Gemini. And this is a research protocol which aims at comparing clinical and economic utility of performing rapid whole genome sequencing. Sequence everything, start from chromosome 1 and end at chromosome 46, the X and Y. versus a targeted sequencing approach that traditionally is done when we follow a diagnostic algorithm. And we sent her for the Gemini. We sent the blood for the enrolled her and sent the blood. And within a few days, we got a result that showed that she had pathogenic variants in this gene, TMM70, a mitochondrial membrane protein. And this is a TMM70 result, a related disorder. Extremely rare. This gene is not present in any panel, cholestasis panel, or mitochondrial panel. And so we now have a confirmation of mitochondrial disease. And what that did for us was we were able to look at the literature and compare her to other patients who, a small handful of patients who've been described worldwide with TMM70 mutations. And we were able to give some prognostic information. And she's now about 10 months old and doing well. She has problems. She's followed with multisystem in clinics with cardiology and so on, but we were able to give the family a result on day of life 15 with no invasive testing. And that is changing the phenotype. And another important thing to remember is if this liver failure was progressive, the next question would be, should we transplant this child? And so these modalities are helping us make those determinations quickly so that our management is more efficient and more tailored to the patient. So this is a cartoon that shows some of the genes involved in mitochondrial hepatopathy and other genes that affect other parts of the GI tract, including the pancreas. And there are some excellent reviews. Here is a reference. And so when we think about mitochondrial diseases and the liver, the childhood onset diseases are pretty severe. And they usually have a hepatocerebral presentation. The brain and the liver are somehow involved together. Think about Alpers-Huttenlocher syndrome. That's a classic mitochondrial depletion due to defects in polymerase gamma, the mitochondrial polymerase. And multisystem involvement with heart, etc., is common. And liver transplantation may not alter the eventual outcome, especially if there is multi-organ involvement, and actually may be associated with deterioration in affected organs. However, an important caveat is successful liver transplantation has been reported in some cases. And in fact, I have the experience of having one of my patients transplanted successfully, and he's doing well, as far as I know, after the liver. So both are common, and you have to have a discussion, and you really need the diagnosis to make all these life-altering decisions. And last but not least, there is newer diseases, including defects of the TRMU gene, which present with fulminant liver failure, catastrophic presentation in the newborn. But if you manage them and support them through it, the liver disease goes away. And then they never get liver disease anymore, and they live eventually come out of that mitochondrial crisis and go on to be pretty healthy. And so identification of those types of diseases is also important. And as our understanding increases, so is our management going to change. So in this ocean of acute phenotypes, the question becomes, especially for the hepatologist, what genetic test should I choose? Should I choose to sequence one gene by one gene because the insurance companies do not want to support panel-based testing? A single gene sequencing may be a few $100s, whereas a simple next-gen panel with a few genes, the starting price is in the 4 figures. And so which one do I choose? Do I choose Sanger sequencing, or do I choose next generation sequencing where multiple genes can be sequenced parallelly all at once? So that is where the conversation should happen between the clinician and the geneticist. And it is definitely a decision that is collectively taken, taking into account availability, finances, availability of research protocols, and also the time sensitivity of some of these tests. So next generation sequencing essentially means that you are sequencing multiple segments of DNA without focusing on a particular gene of interest. And it can be scenario specific panels. What I mean by that is if you have five children with cholestasis, each one of them may have a different inborn error or monogenic cause for the cholestasis. But if you send a panel of genes that is known to cause cholestasis in children, 50 genes or so, then each child will probably have a defect in one of the genes on that panel, and that one panel will give you a diagnosis in all of those genes. So there are panels available for cholestasis, and I'm sure many of you are practicing in hepatology are familiar and have used these, and industry partners, because they have medications used to treat some of those diseases, are increasingly supporting free testing, both in the inpatient and outpatient setting. And if you're not aware, please look up some of these diagnostic testing that is supported by other companies so that it's available to your patient. In cholestasis disorders, inborn errors of metabolism, mitochondrial diseases, lysosomal storage disease panels, etc., are available. And it is great, especially when you have confirmation of a clinical suspicion, is what you're looking for. When you have some signs and symptoms and you think that that's what the patient has. And certainly, it is time and cost saving. The turnaround time is much quicker and it's much cheaper when it comes to reporting, as opposed to whole exome sequencing, where here you're using the same approach of sequencing multiple segments of the DNA, but what you're trying to do is sequencing all the exons of all the genes that are known. So the protein coding regions of the genome. And we use this technology in situations where we feel that the clinical phenotype does not fit neatly with any of these specific scenarios, or if testing using these specific panels is negative and we still suspect that there is a metabolic disease, or it's more of a convenience, a research protocol is available where whole exome sequencing seems to be the better option compared to scenario specific panels. And if whole exome sequencing doesn't pick up, then we resort to whole genome sequencing. We sequence all of the genome, coding, non-coding regions, etc. And so that gives you a lot of data. But trying to figure out what is relevant and what is not relevant is really the limiting factor in whole genome sequencing, because the costs are coming down. And I also would like to mention that when you think of whole exome sequencing, make sure that you are also asking for mitochondrial DNA sequencing, because that's a different genome, as we showed you. So if you're suspecting defect in the mitochondrial DNA, then whole exome sequencing of just the nuclear genes is not going to give you the answer. And always, this is a partnership between hepatologists and geneticists. And so please feel free to reach out to your colleagues in genetics, to us if you have a question, and we will help you interpret and figure out which test to send. There are pros and cons for next generation sequencing. One of the important advantages of doing this panel-based testing or more widespread testing is that the clinical and biochemical signs may be very subtle or absent. Or if you have a very sick child, the liver is already injured and all metabolic pathways are abnormal. So you don't know whether this is, if the child has some fatty acid oxidation type injury, you don't know if it is a fatty acid oxidation defect or if it is because the hepatocyte injury is causing disturbances in fatty acid oxidation. And right now we are dealing with somebody like that in our NICU. And also, if you want, but the child may be very unstable or very ill, and a more invasive testing options may not be possible, such as biopsies and so on. So that's when these tests come in very handy. And as Liz said before, the decision to do or list for liver transplant can become an urgent one. And having a definite diagnosis brings in that security that you are doing the right thing for a given patient. And you can always ask for an urgent turnaround time for next-gen sequencing. And some of these research protocols, that's the whole idea of the Gemini, is to see how it impacts management in the ICUs when it comes to critically ill patients with unknown diagnosis. And the cons is basically the cost, very expensive. Insurance coverage is not uniform, and all of us have a cohort of patients that we are desperate to get some of these testing tools applied, but we are frustrated because it's cost prohibitive. And the other thing is, the technology is there. We can sequence, but we don't know what to do with the data. And there is a big overload of data. It's just coming through, coming at you, and we are getting overwhelmed. We don't understand the nuances of the non-coding regions and how they control the coding regions and so on. And this is an evolving field, and a lot of attention is being paid. So those are the testing modalities that we have. But for a given patient who's presenting to you, we in metabolism, we rely basically on stat labs that will be resulted in the next hour or so. And these are labs that are available in most clinical situations: glucose, ammonia, acid base, LFTs, lactates, CPK, blood ketones. And you get a result in about an hour or two. And if any of these are abnormal, you need to act quickly. If all of these are normal, then you have some time to investigate and take your time and investigate. So really the importance is in these stat labs. And for us metabolic physicians, when we are called in to see a sick child, really most of the decision making is based on some of the critical labs that are going to be available in 1 to 2 hours, as opposed to some of the second-tier metabolic labs, which we will send: lipid profile, uric acid, amino acids, acylcarnitine, etc. But these take a few days to come back. If you have a lab on site, then maybe the turnaround time is quicker, but a few days to a week is the norm for these results, and a sick child does not have the time to wait. So really, the initial management is based on these labs. And when you collect ammonia, make sure that you order it stat on ice. And if it is abnormal, make sure that you repeat it at least once, because sometimes ammonia elevations can be artifactual, and you want to make sure that you're really dealing with hyperammonemia. And then we go through molecular testing. And as I mentioned before, many of us are moving the molecular testing much higher up in the algorithm of the diagnostics in these patients. I mentioned briefly preconception prenatal carrier screening when we were talking about these screening tools. And again, there is no uniformity yet. The American College of Obstetrics and Gynecology recommends a few disorders that are mandated, and requests OBs to screen pregnant couple or people who are planning a pregnancy, to make sure that disorders such as Tay-Sachs and cystic fibrosis, etc., are excluded. But some of the commercial labs have expanded the number of conditions. In our lab here in Sinai, the Semaphore lab screens for about 283 disorders, and many labs are around this number. So what they are doing is they are doing next generation testing for 283 conditions that can be transmitted to the offspring. And when parents know that they are carriers for the condition, when one partner knows that he or she is a carrier, the other partner is tested, the genetic risks are assessed, and that's what the prenatal genetics team is excellent in doing. And if there is a risk, then the couple can opt to explore prenatal testing options or other IVF and other reproductive technologies. And there are many inborn errors of metabolism that are covered in these list of disorders. And what we saw in some patients is that we were testing the couple to see if they were carriers or not. Turns out that one of the partners may actually be affected, but may have subclinical disease. And we've picked up patients with Gaucher disease and Wilson's disease, and they have no overt symptoms. But when you question, then they come up with and say, yes, I always had a large spleen, a liver and a large spleen, but it was stable, and my pediatrician had seen it for many years, and since it wasn't getting worse, There was nothing to do, but I know that I tire easily and I bruise easily and I'm always anemic. Oh, by the way, you have Gaucher disease. So some of those subclinical, and sometimes these patients are asymptomatic. So some of those phenotypes are emerging. And there are some disorders which are not covered by newborn screening, but parents have been identified to be carriers, and we confirm the diagnosis in the child. So I follow a child with hereditary fructose intolerance who was picked up because her parents tested positive to being carriers. She's completely asymptomatic. She avoids fructose and sorbitol, and even the Tylenol and the medications that she takes do not contain sugar or sorbitol, and she's absolutely thriving. And this is really poignant because my other patient with hereditary fructose intolerance that I saw was an 18-month-old who was misdiagnosed as a CDG 10, 15 years ago because we didn't have the technology, and was having a lot of failure to thrive and liver disease, and was put on an elemental formula that has sucrose. And inadvertently, we were making the disease worse by feeding him sucrose, and 50% of sucrose is fructose. So that those type of catastrophes can be avoided with these screening. And once we know the diagnosis, medical intervention and anticipatory guidance changes for these pre-symptomatically identified patients. So here is a 24-year-old girl of Ashkenazi Jewish descent who came up positive for two mutations. She's homozygous for a mutation in this gene, which is the citrin transporter, the aspartate glutamate transporter, important in urea cycle metabolism. She's reportedly healthy, normal liver function, but when we probed, she said she has very unique eating habits, avoids carbohydrate because they make her sick, prefers a high-fat protein diet, cannot tolerate alcohol. And when we did she said her brother has the same symptoms. So it's an autosomal recessive disease, so it makes sense. And when we did the ultrasound, this asymptomatic healthy woman was reported to have some degree of hepatic steatosis. And we diagnosed her with citrin deficiency. And the phenotype is they can present very severely with neonatal cholestasis, or like this with some food avoidance and steatosis. And some of these adults can go on to have metabolic decompensation, high ammonia, neuropsychiatric manifestations, seizures as adults. So now that we have the diagnosis, we can address it, we can put her on a metabolic diet and control her symptoms and manage her expectantly. And this is common in Japan, in Taiwan, and in the Far East, and thought to be rare in the US. But one of my colleagues, Dr. Oishi, his research is on citrin deficiency, and he's following these patients, and he's seeing some variants that are common in the Ashkenazi Jewish population, something we never knew existed. And with a prenatal carrier screening, we now have an emerging phenotype of a disease. Moving along, we've talked about acute liver manifestations. Now, some of the more chronic, insidious liver disease, classic examples are the lysosomal storage diseases. Very interesting group of disorders. We have a very busy lysosomal center here in Mount Sinai. And this is the spectrum. They are individually rare, but as a group, they are fairly common. And I've highlighted for you those diseases where hepatosplenomegaly is a clinical feature. And other organ systems may be involved depending on the disorder, brain, bone, joints, etc. And in fact, I got into metabolism as a specialty because even as I was training, we had treatment for these diseases. So recombinant enzyme replacement therapy is available for several of these diseases now. And I have highlighted those that are can be picked up on the newborn screening in blue. New York State screens for some, but other states screen for others, and the rollout is gradually going on with newer diseases being added. And in addition to enzyme replacement therapy, novel therapies whereby if you are unable to metabolize a substrate, is there any way in turning off the production of the substrate? So substrate reduction therapy pharmacological chaperone therapy, etc., are being explored, and some of them are actually FDA approved. For Gaucher, there is an oral drug. Before, they had to take enzyme replacement every 2 weeks. Now they take a pill. The Fabry patients, some of the mutations are responsive to an oral medication and they avoid enzyme replacement therapy. So these are all active in our clinical practice. And for some patients with more severe disorders, hematopoietic stem cell or umbilical cord derived stem cell transplantation is offered. Research is active in this field. Newer therapies are being developed. This is acid sphingomyelinase deficiency, and is associated with Niemann-Pick A, which is the severe end of the spectrum presenting in children, and Niemann-Pick B, which is the milder end of presenting in older children and adults. Hepatosplenomegaly, and I bolded the spleen because this is an MRI of one of my teenage patients that I followed. Liver, and look at the spleen all the way up here. And I remember one of our residents said did not feel the spleen because her palpation was at this level, just below the costal margin, and you can easily miss something that is in the groin across the midline. So they can have interstitial lung disease, bone marrow infiltration, and CNS involvement in the childhood form, but the adults may have this painless splenomegaly, hypersplenism, fibrosis. And typically, these patients have a pro-atherogenic lipid profile. And the reason is lipoprotein metabolism is altered due to the accumulating sphingomyelin. And previously, we were doing bone marrow biopsies and liver biopsies to diagnose the storage, but nowadays we're just doing non-invasive testing. Enzyme, and then if we cannot measure enzymes in some diseases, we suspect lysosomal storage diseases, we send the next generation panel for LSD, just to make sure that we are not missing something. And newborn screening and prenatal carrier screening options are also available. And a clinical trial is in progress. An investigational recombinant enzyme developed in Mount Sinai is in relatively advanced stages of trial. And here is a cartoon that shows the accumulation in purple. And within a few months, weeks of enzyme replacement, the accumulation is being cleared. The deposits are going away. And this, in this case, study was associated with overall improvement in the lipid profile. So hopefully this will reach FDA approval soon. So we in Mount Sinai are actively involved in solid organ transplantation for metabolic diseases. This is a 10-year data. We've transplanted about 21, 16 liver, 5 combined liver kidney. And in the last 30 months, we've transplanted 12 patients. And what happened around this time was we established a combined liver metabolic transplant program. And the team of hepatologists, transplant nurses, and so on will meet with the metabolic team, including dietitians, metabolic attendings, social workers, and our nurses. And we carefully discuss patients. The metabolic team identifies patients who may benefit from transplant. The workup and listing is then done, and it's a collective approach, and you can find some details on our website. And this is what we have transplanted in the last, since we've started this program. And it is not a cure, and these patients do have other problems associated with rejection and other infection and so on. But this data is quite striking in that the number of metabolic decompensations has plummeted after the liver transplant. And some of these patients were literally living in the hospital for a year or two before the transplant, acutely ill with bicarb. I remember one boy who had a bicarb level that was unmeasurable. And we almost lost him. And this happened many times over. And after the transplant, I haven't actually seen him since his transplant in November. And occasionally he shows up for follow-up in our clinic, and all of us rush to see him, the VIP that he is, because the impact is striking. And this is some unpublished data from Dr. Oishi, who leads the service from the metabolic end. future, we are actively involved in clinical trials. We have gene therapy trials that are liver targeted, not just for liver metabolic diseases, but also for lysosomal diseases where a transgene and in an AAV virus mediated transmission can populate the liver and produce an enzyme. So that's the concept in Fabry disease and urea cycle defects, and other centers are doing for other diseases, including Pompe. RNA-based therapy, this is small inhibitory RNA. Patients with acute hepatic porphyria, if you stop the accumulation of toxic metabolites by using inhibitory RNA, the porphyric crisis resolves. And this is a drug that was in trials in our institution and was recently FDA approved, givosiran. And my colleagues are involved in mRNA-based trials for urea cycle defects, PKU, and so on. And last but not least, we are all waiting expectantly for advances in hepatocyte transplantation because organs are limited. And for some of the metabolic patients, the hepatocyte transplantation is probably an attractive bridge or a definitive treatment. And hopefully, this should happen soon. So to conclude, incorporation of genomics in the diagnosis and management of liver disease is increasing. It's made its presence known and felt in liver clinics, and genomic tools may replace or at least precede invasive diagnostic testing. And we can reserve the tissue diagnosis and biopsies when the genetic test is unrevealing or needs more validation. And once the diagnosis is nailed, the emphasis is going to shift towards how do we treat these things, and this will enable precision medicine approaches. Especially pharmacotherapeutics is a big field that's emerging, as we know, and genetics is technology is the underpinning for that approach. With screening tools, early diagnosis, and novel therapies, they are actually changing the natural history and spectrum of inborn errors. And in the next decade, we are poised to see the development of newer and effective therapies, including DNA or RNA-based treatments, or even others, and biomarker development. And this cannot come soon enough for our patients and for our families, because the burden of these diseases is too heavy to bear in many situations. So this is our program, the Inherited Metabolic Program. We have 4 attendings, and we are ably supported by our genetic counselor and our newborn screening nurse and physician assistant. And there are 2 dietitians who are phenomenal, and a social worker who keeps everything moving. And we have telegenetics initiative, and you can contact us if you need help with any of your patients, either by referral.
Thank you so much for joining us today. Unfortunately, we don't have time for any questions, but you can feel free to reach out to us directly. Thank you so much.